Let us understand today the effect of longitudinal monitoring using ctDNA in a cancer like NSCLC or non-small cell lung cancer. When it comes to NSCLC, the standard of care is basically using TKIs or targetable agents against ALK, ROS, MET and RET. But what happens if there is a resistant mutations? Can it derail the entire standard of care plan for NSCLC patients? Let us try and understand that using our clinical trial. We conducted a prospective clinical trial using 75 NSCLC patients where circulating tumor DNA was evaluated at the baseline as well as during the course of therapy for 1 year. What we found out in this case was that at the baseline, patients who had mutated EGFR also had other concurrent mutations in other pathways like PIK3CA, PTEN, BRAF, and more than 36% people also had co-occurring mutations in TP53, NF2 and RB1, indicating that the standard of care treatment will no longer be eligible in such cases. Further, if you see, 90% of the non-responders had a baseline resistant alteration that was detected in ctDNA vis-a-vis just 20% among the respondents. Further, those patients who had a baseline resistant alteration showed dismal progressive-free survival and overall survival compared to the responders. Also, when we use tumor fraction as a value add in this test, we identified that the change in tumor fraction value correlated very well with the clinical endpoint, wherein an increased tumor fraction load was found to be correlated with very dismal overall survival and progression-free survival. So what does this short assay basically help the patients identify or the doctors identify over here? Using ctDNA as a tool for longitudinal monitoring is very important to classify patients as responders and non-responders at the baseline itself, and that is the biggest value add that today a longitudinal monitoring test can offer in precision oncology.